Hi, I'm Brian Catterley from the Hendersonville Rural Family Medicine Residency Program. You're watching The Black Bag. This episode, we're going to be talking to Dr. Gail Clary, pulmonologist at Pardee Hospital here in Hendersonville, North Carolina. I know reading a bunch of x-rays might not seem like the most exciting thing in the world, but it's not every day you get to read it with one of the best pulmonologists in the country. I know I learned something today. I know you will too. Enjoy.
Part of knowing what an abnormal x-ray is first knowing what constitutes a normal chest x-ray. Part of what determines how good a chest x-ray is how well the person taking the x-ray has lined the patient up on the screen to take the picture. Is the picture rotated? Is it centered? So the first thing is the alignment. What you want to be able to see is that the trachea is in the middle of the x-ray, the left clavicular head and the right clavicular head are centered and are not rotated to one side or the other, because if the film is rotated, then one lung is going to look a little different than it should. So you look to see, is the film centered, and this one is nicely centered. You always want to make sure you get the apex of the lungs, and you want to get the costophrenic angles. People with big lungs, like with emphysema or big people, sometimes it takes 2 or 3 films just to get all of them. You don't want to miss an angle here, because you might miss an effusion, and you don't want to miss the apices because you might miss a pneumothorax in someone who's upright. This is a well-centered normal x-ray. You want to look at the bony structures, the clavicles, each of the ribs. Count the ribs to see that it's a good inspiration. This person has 1, 2, 3, 4, 5, 6, 7, 8, 9 ribs that you can see. So it's a well-expanded lung. You get a little bit of part of the shoulder girdle up here. It's not well seen, but sometimes you can pick up subtleties of shoulder arthritis, broken bones, looking at the clavicles. On a standard chest x-ray, you may or may not be able to tell rib fractures. Obviously, this is a normal x-ray. All the ribs are intact, but sometimes you'll see scars from old rib fractures or deformities that would tell you someone's had an old fracture. Fresh fractures are often hard to see. The bony structures are normal on this patient. The exposure is pretty normal in that you can somewhat see the lumbar and thoracic spine behind it. You shouldn't see all of it. That's an over-penetrated film. You should be able to see at least a little bit of it unless it's under-penetrated. So I look at the bony structures first. I look for the symmetric nature and placement of just the technical aspect. On some films, you can tell what the position of the x-ray is based on how the technologist has done it and whether or not they cheat and tell you with a little indicator up here that it's an upright film, a portable film, a flat film, and on this particular film, we can't tell other than they've told you which is left. And obviously, we should know what's left on most people because the heart is on the left side, except for those few people who have dextrocardia. After I look at the bony structures, then I look at the soft tissues. This person is not terribly fat or skinny. They have a fair amount of soft tissue. There's no air in the soft tissues outside of the chest. The heart, being a large soft tissue in the middle, is of normal size. The edge is normal. There's no obvious lucency on the edge of the heart to make you worry about pneumopericardium. This is the edge on the right side of the heart. The other soft tissue structures in the chest, we always look for the aortic arch. We look for the pulmonary vasculature, the left pulmonary artery trunk here and the right here. These are normal size. In men, normal pulmonary artery is up to about 16 millimeters, I believe. In women, it's 15 here. The other soft tissues that you're looking at other than outside the chest and within the mediastinum would be what's below the diaphragm. Of course, the right diaphragm is here. In most people, it's a little higher than the left, which is here. You look at your costophrenic angle, and those are sharp, so there's no air or fluid in those. And then you try to get an idea of what's under the diaphragms, and certainly on this film you can't see much of anything other than a little bit of air, probably a gastric bubble. But what you don't see is any free air, and sometimes on an x-ray, you actually get the bonus if someone has an upright x-ray and, say, a perforated viscus, you might see free air under their diaphragm. There's no fluid here. It's demonstrated by a sharp costophrenic angle. The other things that make this a normal x-ray, other than the normal bony structure, the good inspiration, the normal heart size, is that the lung parenchyma itself looks normal. Remember that x-rays are only a picture of the difference in in densities: air density, tissue density, fluid. And so in the lungs, you're looking at basically expanded air density with vasculature here and the bronchial tubes, which you really can't see very well on a normal x-ray, and you really shouldn't see. Down here, there may be just a little bit of prominence of the bronchovascular markings, but overall this is a pretty unremarkable normal x-ray, well expanded, normal lung volumes, normal heart silhouette, and no obvious abnormalities that we tend to look at. Our human eye would take us to look at what's abnormal first, but you have to get an appreciation for what's normal before you just zone in on what is abnormal, or else you'll miss other things. The vasculature stops about 1 centimeter from the edge of the chest wall, so it does not look to be any interstitial lung disease or pulmonary edema. There's no obvious mass, no infiltrate or effusion. Now, the important thing about taking x-rays is that you don't just take an AP x-ray or a PA x-ray. You should always take a lateral when you can. The reason that you want to take a lateral x-ray is that there's a lot of stuff that can hide behind the heart in particular. And in the years that I've been practicing, I've seen lung masses, effusions, and other things that are missed because people don't take lateral x-rays in their office. So if at all possible, it's a good idea to be able to not only take them, but know what you're looking at. So on this lateral x-ray, this was taken with the left side of the person's chest closest to the film. And again, we tend to hone in on what the obvious things are, but if you're methodical, you won't miss anything. So again, this is the anterior chest wall, and actually this person has just a little bit of a pectus deformity. The spine is back here, and the rule of thumb is that on a well-penetrated lateral x-ray, you should be able to follow the spine all the way down to the diaphragm. If the spine disappears, then there's something obscuring it, and that would have to be a density that is greater than bone density. What would that be? That's usually fluid or infiltrates, and it's actually called the spine sign. So if you lose your thoracic spine back here, it's because there's something here that shouldn't be there. The heart silhouette is here. The posterior edge of the heart here is never supposed to be much beyond where the inferior vena cava comes across, and that is probably that white tissue line there. Now this is obscured a little bit in that there's an air density here, and that's pretty much normal. Sometimes you will see an air fluid density behind the heart, and of course that's usually a hiatal hernia, which will sit right there. But the heart size is normal here. The retrosternal air space should not have a lot of air in it, as this one is fairly grayed out, because what you should be having come off here is the aortic trunk, and then it circles around to the ascending aorta and then the descending aorta. What you can't see well here is a distinction of the pulmonary arteries that cross over the right and the left, and they're seen on FOSS here. The trachea is here, and you lose it here when it starts to branch to the left and right mainstem bronchi, which are also on FOSS. The diaphragms are well visualized here. The right diaphragm is the one that goes all the way across, and the left stops at the heart on this, the way this is shot from the left side. So this is a pretty normal lateral x-ray. What people tend to miss sometimes are the lung masses that sit here, either in the right lower lobe superior segment behind the right side of the heart on the front view, or the left lower lobe superior segment. These would all be obscured back here behind the heart. Sometimes small effusions. If you have less than 500 milliliters of fluid in the chest, you may only see a little capping back here, whereas you're not going to see it on the front view. So it's very important to always try to get a lateral view and know what you're looking at.